This lecture series on urinary system pathology. This lecture will be covering bladder pathology. As far as bladder pathology goes, there is a handful of things that we're really good at seeing with ultrasound. Unfortunately, though, if the bladder is not full of urine, we're very limited into what we can see because it is collapsed upon itself and it makes it a little bit trickier to see any solid structures. So because we're not very good at seeing all the structures in the bladder, cystoscopy is actually the gold standard for looking at the bladder. During a cystoscope exam, a very, very tiny camera is put in through the urethra and then into the bladder. And then the doctor, the nephrologist, looks around, or the urologist, looks around with the camera and can physically visualize all the walls, much better at seeing any sort of lesions on the walls because ultrasound can only detect lesions that are over 5 millimeters, half a centimeter on the wall. And again, we have to have a full bladder to see that as well. There are very small transducers that fit on the end of a transurethral transducer. So again, a tube is inserted in through the urethra up into the bladder, and then they can do ultrasound through the urethra. That is going to be much more specific to finding those smaller bladder tumors. There's also lots of reasons that somebody might come in for a bladder ultrasound. Quite often we're looking at the bladder in conjunction with the kidneys. Sometimes we just look at the kidneys, sometimes we look at kidneys and bladder. Very rarely are we just looking at the bladder. This list here is not by any means a complete list, but it is a lot of the reasons why a patient might be experiencing incomplete emptying of the urinary bladder. Whenever we have a patient that has issues with emptying, we will definitely want to do post and pre-void measurements on that bladder. Again, we will typically have the patient prep with a full bladder. We scan the bladder, looking at the bladder wall, looking for any sort of obstruction. We will measure the amount of fluid in the bladder, have them go to the bathroom, and then measure the amount of fluid left over in the bladder after they're done. As far as the list goes, don't waste your time memorizing this list. I think the two that are probably, maybe the three, that are probably the most prominent from what I have seen are going to be neurogenic bladder, the Foley catheter, and looking through the list here, I guess technically the neoplasms, benign or malignant, we can have an enlarged prostate that can cause incomplete emptying. So here on the left, I have a picture of that prostate. I like to grab a picture of the prostate when I am scanning males, just to show the radiologist that this might be a thing, maybe it's not. We can see it really, really well, typically in transverse. A prostate that measures larger than 5 centimeters in transverse is worrisome for a hypertrophic prostate. And so that could be part of their problem. This here is the prostate and long. You can see that it's extending into the bladder lumen. The bladder wall is wrapping around it. This is the urethra coming out right here. And it makes sense then if that prostate's enlarged, it's pushing down on that urethra a little bit more, causing the patient a hard time to empty their bladder. The other thing that we quite often see on inpatients is something called a Foley catheter. Now this Foley catheter is a catheter that's inserted in through the urethra. To keep the catheter in place, they then inject a small balloon with some saline, and that's going to keep it situated nicely within the bladder. So sometimes we'll see an incomplete emptied bladder along with the Foley catheter balloon within it. If a patient has a Foley catheter, you should know they should have a urine bag with them. And then you always want to take a picture of it, just kind of show the location and show how well it's working. One thing that we can diagnose by ultrasound, especially if that bladder is nice and full, are bladder diverticulum. Diverticulum in general just mean kind of little pockets. You may have heard of diverticulitis. That's an intestinal disorder where there's little pockets in the intestines that food can get stuck in, and then when that food sits in that little pocket for too long, it starts causing an infection. So bladder diverticulum are little pockets, little outpouchings off the bladder wall. Urine can sit in there and then cause infections of the bladder as well. So here is an example of a patient that has two diverticulum. They have little necks that you can see connected back into the main lumen of the bladder. And then there's these little outpouchings. So here's the neck, little outpouching. They can have one, two, multiple ones. It just depends on how their bladder is set up. Cystitis refers to an infection of the bladder. If a UTI, urinary tract infection, is around long enough, it can result in cystitis as well. So that is one way that we can get it. There's also other non-infectious reasons that we can get it. But usually it is going to have something to do with urine hanging out in that bladder for way too long. Bacteria start to develop and start to just be very irritating to the bladder. Typically, our bladder wall shouldn't measure any more than 6 millimeters, and that's when it is in its decompressed state. So a very full bladder or mildly full bladder that's measuring really more than 3 or 4 millimeters might be suspicious for cystitis. So we're going to have a very thickened wall. If we put color on this, we might see that there's a little bit more blood flow due to inflammation. Bladder tumors are also a thing that can happen, and we already talked about transitional cell carcinoma. That is the type of carcinoma that is most likely to pop up in the bladder. In fact, 95% of tumors in the bladder are the transitional cell carcinoma. They do need to become large enough to where we can detect them. Again, ultrasound can only start to detect lesions that are at 0.5 centimeter. These patients are typically going to have blood clots in their urine, probably painful urine, and feel like they need to go quite often. Here's an example of a bladder tumor. It is just going to be an irregular mass that arises off the bladder wall. Again, they can be very small, they can be very large, they can be finger-like projections, they can just look like almost like a thickening of the wall. So we really want to make sure that we are sweeping through that full bladder, really examining all portions of the wall, looking for any irregularities. Here's another example of a transitional cell carcinoma within the bladder. This is a very large lesion. This is very far progressed. And with that, we are done with bladder pathology. Join us for the next one for ureter pathology.